Good morning. I'm Dr. Gwen Cohen Brown. I am an oral and maxillofacial pathologist. I am a dentist, and I did another 6 years of postdoc in pathology. I'm about one of 100, no, let's see, there's about 150 of us on the East Coast, and there's about 2,000 of us worldwide. So if you've never heard of what I do for a living, that is okay. Basically, nobody has. I've been working with the AIDS Institute since 1992. And in recent years, I've written the monograph for the oral lesions in HIV seropositive patients for New York State for the Department of Health, and which has been adopted as a standard of care for about 8 states on this part of the country, and Texas and California. And I'm also working on the standard of care for the country through Johns Hopkins and the AIDS Institute, writing the chapter on periodontal disease. I work in the dental hygiene clinic in the college and in the Department of Dental Hygiene. What we're going to talk about today is HIV/AIDS, sexuality, STDs, and HIV transmission. And I will slow down and not talk so fast now. We're going to start with sex and the basics, and I know that most of you already know most of this, but we're just going to go through it anyway. The average age of the first sexual contact is in the United States is 16. It has remained the same probably for the last 15, 20 years, and depending upon which state it is, it can be a little bit younger, a little bit higher. New York tends to be around 15 or 16. The average age, however, of inner-city youth is around 13. So we are having people who are getting involved with sexual activity at a much younger age, especially in the New York City area. The onset of sexual intercourse precedes contraceptive use by approximately 1 year at this point in time. Only about 25% of sexually active inner-city youth are using condoms correctly and regularly. Correctly is incredibly important and key to this conversation. And 1/4 or 1/4 of all new STD cases are diagnosed between the ages of 15 and 19 nationally. I know you all know this, but I talk about this with my class as well, and what I teach is pathology. So we talk a lot about sexually transmitted diseases in my school, in my department, and I spend the first day of class sitting there going oral, anal, penile, genital, vaginal, back and forth all day long, and people have to understand, A, that this is what real life is about, and B, they can't be embarrassed about it, because if you're embarrassed about any of this, you can't actually have a conversation with your patients, you can't have a conversation with your clients, and if you're uncomfortable with these words, your peers will be uncomfortable, your patients and clients will be uncomfortable as well. So the one thing I would strongly suggest is just throwing these words out randomly at any given moment in social situations and see what happens. So genital contact in general, we can have oral genital, genital anal, and oral to oral contact. All of these are considered sexually transmittable ways to have a sexually transmittable disease. In terms of sexual identity, sexual orientation, to whom you are attracted to, whether it's men, women, or both. Sexual identity also is how you describe yourself to yourself as well as to others. And sexual behavior is basically with whom you're having sexual relations with. In terms of statistics, and this is for this country at this point in time, which is 2015, exclusively heterosexual basically are between 75 and 80% of males, 80 to 90% of females. Exclusively homosexual, 40% of 4% of males and 2% of females. And people who consider themselves to be bisexual are between 10 to 15% of males and 8 to 10% of females. So there's a lot of fluidity in not just how people have sex, but with whom they're having sex and how often they're having sex and whether or not they're staying within their own gender or being heterosexual. So the question that people ask me a lot is, are you normal? And for me, the answer is yes. I mean, whatever makes anybody happy is what's going to be normal for them. Whether or not other people perceive it or behave appropriately is an entirely different situation. But it's normal for you, and therefore it's normal. So whether it's male-male, male-female, or female-female, that's perfectly fine. You just need to feel comfortable. There are, however, subjective experiences as well, which are wishes and fantasies that are measured by behaviors and specifically masturbation or nocturnal fantasies in general that arise as a result of wishes and fantasies. And even though people may not necessarily consider themselves to be sexually attracted to someone of their own gender, that does not necessarily mean that it's not going to come out in their subconscious or in their night experiences. in terms of what sexual arousal is, sexual arousal for women, we usually say turned on. It's a tingling, warm sensation. Most women are not really accurate and able to estimate the level of vaginal lubrication that they have for themselves. With men, obviously, with being turned on, it's a tingling, warm sensation as well as an erection in general. Not always an erection, but most of the time, yes, especially for young people. The signs, the clinical signs of physiologic arousal are going to be female, which is a vaginal lubrication, and male, which is a actual erection. So, is it a phase? That's a really hard one to ask. I think that most people at some point in time, whether they acknowledge it or not, or whether they state it out loud, have gone through some period of time in their life where they've been attracted to somebody within their own sex, within their own gender. Most people in general at this point in time in the country are still not necessarily considering that to be homosexual or lesbian behavior, women to women or male to male behavior. However, strictly identifying as gay, it's a subset of men, a small subset of men who have sex with men. Most men who have sex with men don't do it all the time. And that they also do have sex with women, but it's a very small subset, only about 4% of people who consider themselves to be primarily gay, and that they only have sex with men. I am going to throw this out there because this is still something we're seeing, and actually one of the things I will tell you we are seeing a lot of, and I see this in my patient population, and my patient population for my private office, not so much at the college, but when I have patients who I'm seeing on a private level. Two things. One is most of the men that I see who have sex with men, and that, by the way, is the CDC criteria. You can say gay, you can say lesbian, but it's as far as the CDC criteria are, they consider it either men having sex with men or women having sex with women is how they define it, is that most people will not necessarily come out and say, yes, I'm gay. They will say, oh, I occasionally have sex with men. As far as the CDC criteria are concerned, for HIV status, if you've ever had sex with men and you're a man, that's most likely how you became HIV positive, with one caveat. And the caveat is IV drug use. If you have had IV drug use even once in your life, even if if you're a man who's only had sex with men without protection, even if you've only had sex with men without protection and you've used IV drugs once, you're considered under the category of an IV drug user, and you're not considered to have acquired the disease through sexual means. Now, having said that, what I will also say is I'm seeing a huge increase in young men who are becoming HIV positive, and I think that there are multiple reasons why this is happening. I think part of the reason that this is happening is that people consider this a chronic disease at this point. They're not really considering it to be something that people die from. Now, as somebody who became a doctor in the mid-'80s in Manhattan, which probably makes me a lot older than most of you, when I started first seeing HIV patients, my patients didn't live. I mean, they were dying quickly, and they were dying within years. I had one patient who was diagnosed with a large cell lymphoma, which is one of the diagnostic criteria for an AIDS diagnosis in an HIV-positive patient, who went from initial diagnosis of HIV disease to dying within 4 weeks. So not only were people dying quickly, they weren't receiving appropriate medications, which they didn't really know what the appropriate medications were at that time, but they didn't really have the same armamentarium of medical devices that we have now. So we do expect people to live longer, but we're also hoping that people get diagnosed earlier. One of the biggest stumbling blocks, however, is that people aren't honest. And so I'm going to strongly suggest that when you go see your doctor, whether it's your dentist, your physician, osteopath, I don't care who you see, that you let them know what you're doing, with whom you're doing it, and they can help figure out whether or not you're in a slightly increased risk group. But I'm seeing more HIV-positive young men than I have in a really long time, and I think part of it is that they didn't see their friends die. I saw my friends die. I saw my patients die, okay? So that my idea of what high-risk activity is may not necessarily be what your idea of high-risk activity is. And my idea of what happens when somebody is HIV positive has been skewed to some degree by the fact that I had so many deaths around me and that you haven't. But that doesn't mean that you can just go and have sexual activity with somebody without taking precautions. So we're seeing a lot more of our young men who are doing barebacking, who are not using any protection at all. And so one of the situations that we're still seeing, and unfortunately this is in more of the African American community than it is outside of the African American community, which is incredibly important because of the social stigma involved, of some of the emotional components that are involved, that a lot of African American men who are having sex with men, and that is the criteria again, men having sex with men, are not necessarily telling their partners they're in a married relationship or a heterosexual relationship, they have children. They do not consider themselves to be gay. And because of this, a lot of people who are in this sort of multiple world situation are not necessarily using precautions with the male partners, and as important, they're going home and having sex with their female partners without using precaution as well. So we are seeing a couple of areas of increased seropositivity. One is in men who are having sex with men in general, and we are seeing sort of this subset of African American men who are having sex with men are not going back and talking about it with their partners, and that is a huge issue, and it's been addressed socially, it's been addressed in the literature, in the peer review literature as well, and it's sort of one of these unspoken conversations that really has to become more public. Female to female transmission. So the biological risk for HIV transmission from female to female non-heterosexual sex is basically thought to be low. The United States at this point in time and the CDC are recommending that women who have sex with women do have precautions, so that they're recommending the use of either a female condom or a rubber dam, which they started making in lovely and delightful flavors like banana and wild cherry, because they sort of want to have something in between your mouth and the labia, and that will also help prevent transmission. You're basically preventing having oral or vaginal contact with someone else's secretions, and that's the main goal for that. Because HIV can be found in genital secretions, menstrual blood, and breast milk, exposure to these fluids are the forces that are driving any female-to-female sex that could potentially lead to HIV seropositive seroconversion. However, I will also say that the likelihood of someone who's who's basically saying that they're a lesbian or only has sex with women, that the incidence of HIV seroconversion is much lower in that population than it is in either heterosexual or men-to-male sexual relations. In terms of heterosexual sex, we are seeing a true changing demographic in this country. When the AIDS epidemic first started, and I will also say, to address one of the questions that had been asked by the class, the difference between HIV and AIDS. There are very specific criteria that the CDC and the AIDS Institute and the Departments of Health have come up with that change somebody from being HIV positive, which simply means you've been exposed to the virus, to somebody who has a diagnosis of AIDS. The one that usually comes into play more often than not is the CD4 cell count, which is the killer T cell count. It's this killer cell count. And when that is under 200 in general, that's considered to be a diagnosis of AIDS. Now, there are specific criteria as well, so that something like Kaposi sarcoma, which is a malignancy that tends to occur only in HIV-positive males, that's something that we look at cervical cancer, anal cancer, and we're beginning to see oral cancer as well. But when you're talking about an AIDS diagnosis versus an HIV status, one person has had a series of sicknesses or a decline in health that's more substantial than just being infected with the virus. HIV/AIDS has brought a new examination of what having sex means, and this is something for those of you who are old enough to remember when President Clinton had a little situation in his office where there was a little conversation about what the difference whether or not oral sex was considered to be sex at all, which it is, and it should be considered to be sex, whether anal sex was considered to be sex at all, and if you were having oral sex and you were having anal sex, whether you were still a virgin if you never had vaginal sex, and that's an issue as well. The risk of becoming infected with HIV during unprotected sex is 2 to 4 times greater for a woman than it is for a man, and that is primarily because it's easier for the ejaculate, which contains semen, to get into the woman, and the mucosal lining of the vaginal tract or the anal tract or the oral cavity as well is a little bit thinner, and it's a little bit easier for it to permeate through the membranes. it is more difficult for the vaginal secretions or anal secretions to get into the penis. So therefore, it's a little bit more complicated going from female to male rather than male to female. One thing I would say, however, is that there are different stages of HIV infection. So that when you're, and this is also a response to one of the questions in the class, so that when you're first exposed to the virus, you have about a 6-week window period in time where even if you're tested for HIV during that period of time, you're not going to have a positive HIV test. And we call this the window period of time. And the reason that this is really important is that you can test somebody who has had risky or high-risk sexual activity within the past 6 weeks, and they may have seroconverted, but it's not going to show up. And it's not going to show up until it's been there long enough for the virus to reproduce and present into the lymph nodes. So there is a small period of time between infection and when you seroconvert and the virus has started to multiply in the lymph nodes, where if you're tested for this, you may or may not be visually HIV seropositive at that time. Male to female transmission is more likely because during vaginal intercourse, a woman has a larger surface area of her genital tract exposed to the partner's sexual secretions than a man does, and also HIV concentration is generally higher in a man's semen than in a woman's sexual secretions. Sexual behaviors such as anal intercourse, however, are not linked to pregnancy, but do pose a risk of HIV, AIDS, and other STDs. So this goes back to what we were talking about, well, what is sex? If you're not at risk for pregnancy, which is certainly something that most people are very worried about, and something that is of great concern to most people who are having sexual relations in a heterosexual relationship, that if you are having sex and you don't have to worry about pregnancy, then why do I need to use a condom? And you need to use a condom because unless you and your partner are tested, and then you're tested again in 2 months, and neither of you have had sex with anybody else during that period of time, or have used IV drugs, or have exposed yourself to any other possible risk of becoming seroconverting to HIV, that unless all of these factors are not, basically you've been in a room by yourself for 2 months and you haven't had any interaction with anybody else, then we can say yes, at this point in time you've had 2 negative HIV tests, you're good to go. Yes, you won't get pregnant if you're having anal sex, but on the other hand, the likelihood of passing the virus on in anal sex is actually greater than in vaginal sex, and that is because there's usually more trauma involved. So there's more ripping of the anal lining as well. And for those of you who don't know, anal sex is actually rather common in the heterosexual community as well. Other myths. Let's go through some myths here because these are not true at all. Masturbation causes hairy palms, insomnia, impotence, lack of concentration, and blindness. None of these are true. The bigger the penis, the better. Also statistically shown not to be true, although trying to get people to believe that sometimes is not always easy. And that men can instantly produce an erection on demand while women turn on much slowly. Men actually can't produce erections on demand. For the women in your class, that's hopefully not new knowledge. For the men, it's probably common knowledge. Sexual myths number 2. If we didn't have intercourse, we didn't have sex. That is just out there in not just bad medicine, but it's really a mythology that has to be broken at this point in time. Oral sex, anal sex, vaginal sex, it's all sex. And anything that can pass one secretion from one human being to another person is putting you at risk of seroconverting or being exposed to the HIV virus. And by the way, the other thing I would like to say, because sometimes people get a little nuts and they start thinking, I've been exposed to blood or I've been exposed to semen. How worried do I have to be? The way you have to be worried is basically how has the other person been exposed? Is the other person at risk? Is the other person HIV seropositive? If they're not, then obviously you don't need to. So one of the issues that we have to deal with in clinic sometimes are things like needle sticks. And you have somebody, or instrumentation sticks. So you have somebody who's been working in a patient's mouth and then they accidentally get themselves. So a lot of our students have an automatic panic attack because we've been teaching them about bloodborne pathogens and how things are transmitted between people. And what I have to sort of pull them back and say, but you don't know the patient's HIV status. So even though I'm going to tell you everything is precaution, 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 if you do have an incident, whether or not you've been exposed sexually, through an occupational exposure, which most of our students are concerned about at this point, that even if you do have an exposure, either way, you still have to find out what the patient's HIV status is and whether or not they are someone who you need to worry about for themselves as well as for yourself. And I would strongly suggest, if you have not yet had an HIV test, to have one. When I first had an HIV test, which was probably about the late 80s, early 90s, and I had it for a couple of reasons. One is my patient population, by choice, was exclusively HIV. And so I had HIV tests probably every 6 months for a really long time. And only just stopped having them recently when I stopped seeing as many HIV patients, although I should probably have one again. It was a much more stressful procedure at that point. I mean, you had to have blood, you had to wait for 2 weeks, then you had to go back and you had to have a conversation. The way we're doing HIV testing right now, which you can buy, by the way, at CVS or Walgreens or Genovese, you can do a walk-in, or I know that occasionally you can get them free at the clinic as well, that the HIV testing we're doing right now is a 20-minute rapid turnaround test. It is done by saliva as well as cheek cells, and basically it will give you a negative result within 20 minutes. If you get a positive result, we need to do a confirmation on it, and at that point we're going to send you back to have a blood test, and that will probably put you back into the 1 week waiting range. But the straightforward test, which is really easy to do and easily available, and I think about $30 at this point, is something that you should consider doing if you haven't done one. Getting back to sex myths. The proper way for a woman to have an orgasm is through a penis, vaginal sex only. This is also not true. Lesbians or women who have sex with women and gay men or men who have sex with men are always trying to seduce heterosexuals. Not so much an issue, although for whatever reason people seem to think that people are always trying to seduce the next generation so that they're going to try and convert people to the gay lifestyle, which is actually not happening. Gays and lesbians are oversexed, also not true. Bisexuals have the best of both worlds. I've heard this more times than I want to even think about. I tend to think it probably would cause me a little more stress, but that is not a choice. This is what they are, and this is who they are, so don't judge. And that it's easy to spot a gay lesbian in a crowd. This is not even close to being true. When I started seeing HIV patients, which was a long time ago, I had one doctor who was an oral surgeon who did a biopsy on a young woman who had neglected to tell him that she was a heroin user and that she had just come out of rehab, and he was biopsying the side of her tongue for a AIDS indicator disease, and he didn't use gloves. And he didn't use gloves because he thought he could figure out who was gay and who wasn't gay because he just knew. And it wasn't great. It was not a great situation for him because the woman was HIV positive, and it wasn't great for a lot of reasons. But it is not something you can just tell by looking at somebody. You can't tell somebody's HIV positive by looking at somebody as well. This is my schematic of how the women and men's brains work. This is not true. This is just humor. Okay, let's get straight into a little bit talk about HIV. Let's talk about the statistics. In terms of the CDC and the Center, which is the Center for Disease Control and Prevention, it's out of Atlanta, Georgia. They're estimating at this point in time, and this statistic, unfortunately, has not changed in the last 20 years, that between 20 to 25% of the population who is HIV positive, depending upon where you are in the country, and unfortunately it's a little bit higher in this area, especially in Brooklyn, but 25% of the people approximately in Brooklyn right now who are HIV positive do not know their HIV status. Think of the complications of that, not just for that one person, but in terms of the effect that it's going to have on their lives, their partners' lives, their families' lives. If you are not diagnosed, you can't get treated. If you get treated, the likelihood is you're going to live a relatively normal life and a long life as well. About 40,000 new cases of HIV every year are diagnosed, and half of them are in patients who are under 25. And I've heard more people than I would like to know say things like, oh yeah, I'm not worried about the virus, or I got the virus, or I got it, or whatever. It is not a throwaway disease, and people are really thinking about it a little bit more like things like high blood pressure or hypertension or diabetes than I'm comfortable with. This is a communicable disease, and there are steps that you can take to ensure your own health as well as the health of people you love. So it is something you want to take into consideration. From 1985 to 2002, the proportion of AIDS in women increased from 7 to 26%, and right now it's a little bit higher than that. It's not substantially higher than that. The reason that it has started to increase is two reasons. One, men who are having sex with men who are going home and having sex with their wife, and you have to understand that if you're having sex with men and you're exposing yourself to HIV, and you go home and say, yeah, I want to start using a condom, that's going to create a conversation that may or may not happen, and it may cause some difficulties in whatever relationship you're in, whether it's your wife or your lover. It doesn't really matter, but all of a sudden you're changing the pattern of how things are going. So a lot of men who are having sex with men are not necessarily going home to have this conversation with their female sexual partners, and therefore they're bringing home the HIV virus. The other reason that we're seeing a lot more HIV in women is obviously IV drug use. Now, there are some campaigns, and the clean needle campaigns, needle distributions, a lot of these things are helping significantly because most people, IV drug users alike, know that they don't want to be sharing needles. I mean, there's the risk of hepatitis C, the risk of HIV, the risk of other STDs as well, anything that's a bloodborne pathogen, they don't want to be exposed to it at all. So given the opportunity to use a clean needle, even the most desperate heroin addicted person is going to still choose to be safe over sorry. The other thing I would like to say is that as of right now, African Americans are accounting for 51% of new HIV infections, although they comprise only 13% of the population in this country. And that is a startling statistic. And part of it has to do with the non-discussions that are going on within the community itself, and part of it has to do with the lack of willingness to use a condom on a lot of people's parts, and that is something that I expect everyone to take some responsibility for and prevent that from continuing. In New York State specifically, New York State accounts for over 25% of all reported AIDS cases among women in the United States, which is 31.8% due to heterosexual contact. The rest is from IV drug use. There was a period of time when I was seeing patients in all 5 boroughs, and I was working in multiple hospitals. Basically, if I wasn't in 3 different boroughs during a day, I didn't know what day it was. And one of the things I was finding at that particular time is that, in lower Manhattan, I was still seeing mostly white gay men. In upper Manhattan, I was seeing mostly African Americans who were getting it both through heterosexual sex for the females, male-to-male sex for the men, and an increasing rise of IV drug use. In Queens, almost all my patients were women. I don't really know why. So I don't want you to expect it to be one thing specifically or another. It's really going to depend upon the community that you're in, the group of people that you're around, where your targeted areas of HIV are going to be. And yes, we do still have a greater number of HIV-positive patients who are gay men, but we have pretty much almost an identical number at this point in time of IV drug using or sexual or male to female sexual contact. So all of these groups are growing. The only one group that's really not growing substantially is the gay men, although I have to tell you, my younger gay men are not using birth control, they're not using condoms, and therefore the likelihood is that we're going to start seeing a real peak as well in there. As of 6/2000, 19% of the nation's total AIDS cases were in New York. It's pretty much remained the same. That does not consider only AIDS cases, that's also for HIV as well. Basically, we have a changing epidemiology in this country. The face of the AIDS or HIV patient is changing, the epidemic is changing, and what I would like to say is that HIV is still really significantly disproportionately affecting minorities. So we're talking about the African American community, we're talking about adolescents, which in this case is considered a minority because they're sexually active for a small period of time. And we are seeing an increase in women who are having sex with men who are having sex with men. Those are the 3 groups that we're seeing an increase in. The rates of HIV infection among both African American and Latino youth are disproportionately higher. I cannot stress this enough. I know that we have had in the past baskets of condoms and everything all around the school. I would strongly suggest dipping your hand in there and taking a few, whether you're having sex with men or women. It's a really good idea for protection. While each group, both African Americans and Latinos, are about 15% of U.S. teenagers, African Americans account for 67% of reported HIV infections, and Latinos account for an additional 20%. Think about that. This should not be happening right now, and it shouldn't be happening with the amount of education that our young people are getting, which actually is one question that somebody had asked me during in the questions that you had put up on Open Lab. How can we better educate our children? And although I can tell you what I think, yeah, we need to be a little more graphic, we need to be a little more honest, and the problem is, and this is not your problem, this is the adults around you, okay? So the grown-ups don't want to think that their children will ever have sex because they're so busy being in denial that their children will ever be sexual human beings. The idea of having a conversation about this with their children is impossible. So we are not getting the kind of sexual information that they should be getting when they're in middle school, going into high school, because this is when sexual orientation, when sexual definition really begins to emerge in terms of being acted out. And if they're not getting the information when they start to need it, we are actually failing our students at this point. And I think we really need to do something better. I don't have an idea of what that could be, except that I think we need to be a little more aggressive. In terms of Brooklyn, okay, we have 13,643 people who are living with HIV/AIDS. This was for the calendar year 2001. The statistics, however, have not changed. So this is why some of the older statistics are still being used. When the newer statistics come out, they just sort of add them on to the top of this. And we have in terms of new HIV diagnoses cases, we have 1,465. That's a lot for a year. That's a lot for one borough. Okay, and unfortunately, a lot of these patients who are becoming HIV seropositive are young. In terms of HIV and AIDS in Brooklyn and New York City versus the United States and the Department of Health, this is Brooklyn as a whole, this is New York City as a whole, and this is the United States as a whole. We are double the United States. We're not quite as high as New York City as a whole, but that's because there are still a lot of people who are living with AIDS that are counted in this, who have been alive for some period of time, so that we still have a slightly older gay male population that's still living with AIDS, and we do have more. This is all the boroughs together, so you've got to count Queens and the Bronx, and there's a slightly lower incidence in Staten Island, but trust me, it's not negligible. Okay, so from 25 to 44-year-old people in the year 2001, the leading cause of death among African Americans was HIV infection. That has not statistically changed. That is still incredibly high. I think after that we've got heart disease, motor vehicle accidents, cancer, homicide. I don't think HIV should be number one, but it still is. And part of the reason is that people are getting diagnosed late and they're getting on treatment late. The earlier you're diagnosed, the earlier you start treatment, the less likely it is that your body will be ravaged by this disease. Within the world, there are 11.8 million. It's probably about 14 million now. I apologize for this. Between the ages of 15 and 24 living with HIV/AIDS. Now, they're significantly talking about the ages between 15 and 24. And the reason they're talking about 15 to 24 is that means that those people who were born HIV positive are not counted in this group so much. This is really for those adolescents and young adults who are becoming sexually active. Okay, so HIV transmission itself. Sexual contact, number one, obviously. You can have HIV transmission. It's called vertical transmission when it's coming from a mother to a child. It's lateral transmission when it's between two different people of basically the same age or having sexual contact itself. HIV is passed through the contact with blood, as is with sharing needles, piercing, tattooing. If you're getting tattoos or piercings, please make sure they're autoclaving their instruments. And by the way, that is a perfectly reasonable thing to ask them. And in New York City, now that tattooing is legal, the likelihood of having your instruments autoclaved is much higher, and the likelihood of having HIV or hepatitis C transmission becomes much lower. Sharing works of any kind, which is basically heroin or needles is all, and sharing anything with an HIV patient. It is not transmitted through casual contact. It's not transmitted through mosquitoes. It's not transmitted through, sharing a bathroom with someone. There have, however, been cases where it was transmitted between siblings using a toothbrush. So don't share your toothbrush, which is a bad idea anyway. In terms of HIV particles in 1 milliliter of body fluids, in blood it's 18,000, in semen it's 11,000, vaginal secretions or fluids it's 7,000, amniotic fluid 4,000, and saliva is 1. So of all your choices, your mouth is probably the cleanest possible place to be. Sexual transmission is the most common route of HIV transmission in the world. About 75% of all people who become HIV seropositive have had seroconversion through sexual activity. And that the probability of transmission is based on a few really specific criteria. Okay, how infectious is the person that you're having sex with? So someone who is far into their disease, someone who is in a hospice, somebody who is dying, somebody who has had AIDS for a really long time is going to be significantly more likely to seroconvert someone else if they have unprotected sex with them than someone who has only been HIV positive for a short period of time. One of the questions that was asked earlier on the Open Lab page was if two people are both HIV positive, whether or not if they're having sex with each other, whether they need to use condoms, whether they need to use any sort of prevention method at all. And the answer to that is yes, because there's more than one different viral strain, and that they will compound each other, so that they will actually logarithmically make each other worse, and that if you're exposed to more than one strain of HIV and you have multiple strains of HIV, not only does the likelihood of you running into a medication that is non-effective more likely, because people do get these strains that are no longer drug treatable, but it also, the likelihood is that you're more susceptible to everything else. So your likelihood of having other sexually transmitted diseases, the likelihood of you having hepatitis, everything else is going to grow up. And the more compounding that you have with each of these diseases, the more difficult everything becomes to treat. So when you have which is called a comorbidity, when you have comorbidities, the difficulty in effectively treating either disease decreases significantly. And the two, obviously, that we're most worried about at this point in time are going to be HIV and hepatitis C. So the index of infectiousness basically means two things. How infectious is the person who you're exposed to? And I would also like to say, how well are you? So if your immune system is more intact, if you are healthier, your likelihood of being able to prevent transmission is greater. But I will also say that I've had more than 5 patients who were exposed to HIV during their first sexual encounter, and they did seroconvert. So I don't think that you should automatically go on how well you are, but be more concerned with how well the person that you're having sex is and see how they are. The mode of sexual contact, anal sex is more traumatic than vaginal sex, which is more traumatic than oral sex, and that's basically the road that you're looking at. And so that it's susceptibility of yourself, what kind of sex you're having, and how sick the other person is. So when you put these 3 things together, you have a probability of transmission of disease. Anal sex is the most efficient way to transmit HIV virus sexually, at least 5 times more risky to the receptive partner than vaginal sex. Okay? And that has a lot to do with some of the bruising and the tearing that happens around the anus and around the anal opening when people are having anal sex. And that you do need to remember that not all homosexual sex is anal and not all heterosexual sex is vaginal. exposure to blood. Now, this is something as a dentist, as a pathologist, as somebody who's in people's mouths all the time, I'm constantly aware of. Now, I lecture on, I'm one of 2 people allowed to lecture on infection control for New York State, for the New York State Department of Health. So I do go around to lots of different hospitals and facilities and tell other people how to deal with occupational exposures. And we do have very strict protocols on what we do when you have an occupational exposure or a sexual exposure. And there's actually something new that's called PrEP, which is something has basically been around for about a year, but is only starting to be more widely used. And that's for people who know that they're having potentially risky sexual behavior and that they're taking this cocktail or this medication before they go out. Now, there's mixed feelings about this with people for a couple of reasons. One is, and no offense to the young people in the audience, young people are not so religious about taking their medication. Okay, so if you don't take it one day, the likelihood is that you're going to have a problem. It's not as if you can pop a pill and go out and have sex with people. This is something you do have to take every single day. Okay. When we have had a sexual exposure or we've had a post-exposure with occupational exposure, there's something called post-exposure prophylaxis, and there's a specific medication that you have to be on for a specific period of time, usually 28 days. We are trying to prevent the transmission. So for me, the idea of PrEP works really well, but it has to be in conjunction with the use of condoms. It can't just be used alone. Just because you have something that will prevent you from, or potentially prevent you from seroconverting, if people aren't taking it regularly and they're having unprotected sex, the possibility still exists that they will seroconvert. So, exposure to blood, exposure to semen, and let's talk about HIV testing. There are a lot of different ways of doing HIV testing. Right now, this is the old version. This is basically the blood test, but the paradigm is exactly the same. So you want to have a relationship with somebody, and they want you to get HIV tested. Not a bad idea anyway. So you go, you get HIV tested. You do the oral test, it comes back negative. You've got 6 weeks where you still have to use condoms, you still have to protect yourself, you still have to make sure you're not having sex with other people, you're not engaging in any other risky behavior. After that period of time, you retest. If you're still negative after the second test and neither of the people involved have had any other risky behavior where they could potentially have been exposed to HIV disease, that at that point in time, yes, you may start having sexual relations with this person, but you should probably use a condom anyway. After 6 months following an occupational exposure or following an exposure to blood or to semen that may be HIV positive, after 6 months, if you have not seroconverted, the likelihood is pretty much negligible that you're going to seroconvert. So you want to continue to take tests. So you're taking one at 6 weeks, 12 weeks, and 3 months. Basically, it's the 3-month mark. They're no longer requiring a 6-month mark, but that is an option that if you want to do it, you can. And it really is going to depend upon what kind of an exposure you had. So I had a really terrible bloodborne exposure when I was working in the hospital in the South Bronx, and I was talking to a little boy who is about 6, but he had been born HIV positive and he had failure to thrive, and he was probably about the size of a 2-year-old at that time. And because it's me and I talk to people face to face, I was sitting on the floor in the hallway talking to this little boy, and I wasn't in my gown. I didn't have my glasses on. I didn't have a face mask on. I didn't have anything on. And he projectile vomited blood all over me and died a week later. So his HIV count was probably 700,000, a million. I mean, it was probably through the roof because he was so sick and he died the week after. So, you know, when I talk to people, I usually tell them I had probably the worst bloodborne, one of the worst bloodborne exposures, occupational exposures of anybody I know. And I went on, at that time it was ACT for a month. So I understand the issues involved, I understand the reluctance involved, and I followed the testing protocols very carefully. And but it was incredibly scary, but I would also like to say that. In terms of symptoms, and this is something you should know, most people who are infected with HIV don't have any idea that they're infected with HIV, which is why 20% to 25% of the population still has an unknown HIV status. Because of this, what happens is the initial symptoms are usually overlooked, especially if it's in the winter, because the initial symptoms that you have following your primary exposure to HIV tend to be very flu-like. So you'll get, they call it lymphadenopathy, which is swelling of the lymph nodes. So the lymph nodes around the head and neck, which, and not to mention the ones under your arms and the groin area, but the ones around the head and neck tend to swell up pretty quickly. So they go down, the muscle that goes down the side of your neck, they go under your jawbone here, and a little bit right in front of your ears. Those will swell. People will complain that they have a little bit of a fever, that they just feel a little bit run down. Unfortunately, these are such non-specific symptoms that most people don't associate it with HIV disease, and also, unfortunately, that it's not going to be able to be picked up in the blood or saliva for another 6 weeks after the initial exposure. So there is this window period of time that you do need to be aware of at all times. After time, the symptoms of HIV, or the classic symptoms of HIV, are going to be weight loss, night sweats, diarrhea, loss of appetite, rash, swelling of the lymph nodes again, and lack of resistance to disease. So I would just like to make it clear that people don't die of AIDS. People die of diseases that they get because their immune system is no longer functioning. So that people will die of pneumonia, or people will die of a type of cancer, a specific type of cancer. They're not dying of AIDS. They're dying of other lesions that become more what we call opportunistic infections or opportunistic diseases because the person's immune system is low. And by the way, I would just like to say that there are lots of other reasons that you can get these symptoms as well. So if you've started having any of them right now, don't start to panic. These can be associated with a multitude of other symptoms as well. But if you are having any of these symptoms, you should probably go talk to your primary care physician. Okay, club drugs and HIV. We are dealing with ecstasy, alcohol, Special K, which is basically ketamine. It's also sometimes known as vitamin K, crystal meth, which is a little bit less in this part of the country than other areas, the date rape drug or liquid G, Viagra, and cocaine. You start mixing these things together, and you have a situation where people are having sexual relations with people that they may or may not know that they're having sexual relations with them, whether or not it's on purpose or they're being forced into a situation. And we have a situation of party, which is basically that we refer to in the HIV community as party and play, which is basically doing speed, which is party and having sex. So this is speed, cocaine. Sometimes people are mixing in ecstasy, which, by the way, you should never, ever use if you're ever considering using ecstasy. It causes permanent holes in your brain, so your brain starts to look like Swiss cheese, which is why you have memory loss. In case you haven't started using it yet, please don't. In terms of sexually transmitted diseases in general, there are about 3 million adolescents that will contract a sexually transmitted disease annually, which means that all 3 million of those people are not using any sort of protection. That's a lot of people. 2/3 of the 12 million Americans with STDs are under the age of 25. So we could have gonorrhea, chlamydia, we have yeast infections that are sexually transmitted. There are a lot of sexually transmitted diseases, and trust me, you don't want to have any of them. Most of them are able to be treated with medications, but we're getting a lot of new types of diseases, or they're old diseases that are now becoming drug resistant, so that they're not working so well. And the best example of this, which is not a sexually transmitted disease that you may know about, is tuberculosis. That we have drug-resistant tuberculosis in this country. And no matter what we're doing, we can't seem to get a hold of it or get around it or get ahead of it. And the reason that these drug resistance happen is that people are given prescription medications and they don't finish them. And that means that all the bugs or all the bacterial or microbial organisms that are able to be killed are killed easily. And the ones that would have taken the entire dose to kill, but you stopped taking it because you felt better, those become incredibly strong, and then they become drug resistant. Now, one of the things that happens with treatment of HIV patients with drug-resistant forms of HIV is that that is a really complicated situation. So say you're exposed to somebody who is HIV positive, but they're resistant to one drug. Well, that means that the type of HIV you're going to be getting, if you do seroconvert, is also going to be resistant to that drug. So you've just wiped out one of the drugs out of the arsenal of treatment. So there are a lot of reasons, and that becomes more of an issue when you have multiple strains of HIV as well, which is another reason why if both partners are HIV positive, you still don't want to be having unprotected sex. Other sexually transmitted diseases, you can get these diseases by having sex, vaginal, oral, or anal with someone who's already infected. They have to be infected for you to get infected. If you're having some sex with someone who is not infected, they're not transmitting anything. They can also be spread simply by touching the infected skin. So some things like herpes or genital warts, which are human papillomavirus infections, can be spread through contact. If you have a break in your skin and you touch someone else's lesion, guess what? You've just gotten infected, because that's how the virus spreads. And viruses are very happy to go from one person to another. That's their entire goal in their life, is to spread from one person to another. So sexually transmitted diseases, most of them are spread through sexual contact. However, touching someone in an area where they may or may not have an infection increases the likelihood of you becoming infected. A startling statistic here: 1 in 4 Americans will become infected with an STD during their lifetime. And that the United States has the highest rate of STDs of any developing nation. And a lot of this, in fact, all of it, is because people are having sex without protection. Condoms will help. Female condoms will help. You really need to have some sort of protection, not just for pregnancy, but for any sexual activity. You want to prevent the spread of sexually transmitted diseases, period. Raising STD rates are concerning, not only because they suggest increased levels of unsafe sexual behavior, but because gonorrhea, syphilis, HSV, which is herpes simplex virus, and other sexually transmitted diseases are associated with an increased HIV shedding in the genital secretion, and consequently an increased HIV rate of transmission. So, having a sexually transmitted disease makes you more likely, if you have HIV disease as well, to be able to spread that HIV from one partner to another. It potentiates it. It also increases the likelihood, if the person who is on the receiving end has an STD as well, that their likelihood of seroconverting to HIV once exposed is also greater. So STDs really do play a huge role in the impact of HIV transmission in this country. STDs increase the susceptibility to and the infectiousness of an HIV infection, and that the risk of HIV transmission is 2 to 5 times higher in the presence of other STDs. Bacterial STDs, things like chlamydia, gonorrhea, can be treated easily. They can be cured with antibiotics. Some diseases, not bacterial, but can be prevented by vaccines. And the vaccine that's most likely to come to most of your minds is the HPV vaccine, the Gardasil vaccine, which if you have not had, if you're under 26 and you have not yet started to have sex with people, you should strongly talk to your doctor about getting the vaccine, both men and female, male and females. If you have had sexual relationships before now, you can be tested to see whether or not you've been exposed to HPV, and if you have not been exposed to HPV, you should get the vaccine. Now, my son, who's now 23, when he was growing up, when the vaccine first came out, I literally almost got into a fist fight with my son's pediatrician, because at that time it was only allowed for girls. And I basically was like, how can you possibly tell me that a virus can know what gender you are? And he was like, I'm not allowed to do this. I was like, I will pay for it. He's like, I'm not allowed to do this. And at the time, he wasn't. And currently, the rules are, they have actually figured out that viruses cannot figure out if you're male or female, and that they're now recommending the vaccines for everyone. There is a new vaccine that just came out, which is now has efficacy against 8 or 9, I think it's 9 HPV strains. And in terms of how many HPV strains there are about 130 of them right now that are known human papillomavirus infections. And the only HPV strains that they're working on with the vaccine are specifically those that cause certain types of cancers, whether it's oral cancer, anal cancer, or cervical cancer. Those are the ones that they're looking at. Bacterial infections include primarily gonorrhea, syphilis, and chlamydia. The viral STDs, things like HPV or herpes, cannot actually be cured. Once you are infected with a virus, you will have it for the rest of your life. It will become variably active. So most people, if they're exposed to HPV, if they're really healthy, the virus will clear. If it does not clear, it will get in your cells. It will stay there forever. You cannot get rid of it. It is a virus. It's the same thing with the herpes viruses. Once you have herpes, whether it's oral herpes or genital herpes, it will live in your neurons for the rest of your life, specifically either the trigeminal neuron or the dorsal root ganglion, and that is basically right above the curve of the back or the base of the head. The common viral STDs that we're dealing with are going to be herpes simplex viruses 1 and 2. Quite frankly, I don't care which strain it is, 1 or 2. If you have it, they behave exactly the same way. It used to be that HSV1 was 100% above the waist, and then HSV2 is 100% below the waist, and then oral sex happened, and now it's 65% above the waist for HSV1 and 65% below the waist for HSV2. Human papillomavirus in general, which is a sexually transmitted viral papilloma, which is what a condyloma acuminatum is. Viruses are tiny, very tiny non-cellular particles. They have DNA or RNA as their core and a protein coat. They are parasitic. They will live on you. They will live with you, but they won't do anything for you. And that some of these are and can be prevented by a vaccine. This is actually a slide from the Second World War, where they were having a huge problem with the soldiers coming back with syphilis and gonorrhea because they were having sex with prostitutes in other countries more than they were having sex with prostitutes in this country, probably because they were on their own and that's what they were doing. So this is just an old sign to go get your vaccination, or to go get your penicillin shot at the time. Oral sex itself. So oral sex may carry a lower risk for transmission of HIV other than other forms of sex. Repeated unprotected exposures, especially in the prevalence of syphilis or one of the other sexually transmitted diseases, does represent a substantial risk for HIV transmission. So in terms of data, there are cases that are documented in the literature of specifically men who were using prostitutes, who were only having oral sex and only having oral sex with prostitutes, and that they did have HIV transmission. So you have to start thinking about, well, even though we know saliva is okay, well, sometimes there's blood in the mouth, and sometimes there's trauma in the mouth. And when you're having oral sex, you're exposing your partner to whatever secretions are in your mouth, as well as blood and other sexually transmitted diseases. Okay, so in terms of a prevention framework, it can go any which way. And this is basically focusing on the empowerment for prevention. You're going to work on decreasing any risky behavior, which should hopefully decrease the HIV incidence. You're going to modify biologic factors, which means that you're going to be healthier, so you're going to have fewer STDs, you're going to have other incidents. Your overall immune system is going to be a little bit better. You're going to also talk about what's happening outside of your immediate environment or your immediate body, which is that you want to make sure that your environment is supporting of you being sexually active as well as sexually healthy, and that you know where to go for services and commodities. And I would strongly recommend making sure you have an appointment in the near future to talk about this with your primary care physician if you haven't had one recently. 90% of people, this is just one of our signs that does show up on our bus stations every once in a while, that 90% of people with HIV do not know that they have it. The AIDS crisis is not over. It's just in transition, okay? So that the old base of HIV disease that we used to think of basically as nothing but gay men, that's not what it is anymore. It's a changing demographic. It's much more racially diverse. It's not a bunch of old white gay guys anymore, okay? I mean, when I started seeing patients, my patient population who was HIV positive were all white, all male. It's not like that anymore. In fact, I'm seeing much younger patients and much more ethnically diverse patients as well. These are a list of resources that you can go to. There are places that you can call, and all of this is going to be on the PowerPoint that will be available for you on Open Lab so that you can download it and take a look at it. I'm available for questions as well if you have any. These are the AIDS hotline numbers and the websites. You can also go to the AIDS Education and Training Center, the New York, New Jersey, NYNJAETC, and you can look at they have a great material there. They have everything talking about from how to prevent HIV to how to treat HIV, what the most common medications are, and it has questions about LGBT and transgender and also questioning youth as well. So there's a lot of really good resources available. And that is the end of my specific presentation. So I'm going to talk about a couple of questions that you guys asked, and I know I've answered some of them, but I think one of them I did want to address partly, but I think should probably be more likely to be addressed within your class itself, which is the biggest perception. What is the biggest perception people have of HIV/AIDS, and do you feel that contributes to the increasing population of the HIV seropositive patients? People think they can't happen to them. Okay? I mean, this is the same with everything. People don't get insurance because it'll never happen to them. They'll buy the cheapest car insurance because they'll never have an accident. I mean, people don't ever think that bad things are going to happen to them. So when it does, it's a bit of a surprise. It's always easier for people to think of other people having these problems. So, it's people who are HIV positive and they got that way because they were, having issues with God, or they were doing something that was wrong, or they were being cursed, or, there's a lot of reasons that people think people become HIV positive, which have nothing to do with the reality of how HIV is transmitted. And I think until some of these personal and conscious decisions that people are making are recognized, and that people are less judging of other people, the quietness of HIV is going to remain quiet. People aren't going to talk about it. They're not going to discuss it. I know people who have been in relationships with HIV seropositive patients for 20 years, and they're aware of it, and they have not seroconverted because they know what they're doing and they're conscious of it. I think that the rate of infection is going to increase when you have a patient population or people who are not talking about it, who are not being tested, who don't understand what the risks are. I think that judgment, that religious some intolerance to some degree, that community intolerance to some degree, all of these things play into how we judge people who are HIV positive, and not just looking at it saying, okay, well, they have something, we can treat it and they can have a normal life, or a relatively normal life, with medication, with understanding that, yes, everything has limits, and it's not something that you want to pass on to somebody else. In terms of the vaccine, which was a great question, what are the thoughts on working towards an HIV vaccine? And in conjunction to that, also a great question, do you see this as an opportunity for individuals to continue to participate in risky behaviors as opposed to make safer decisions? That issue itself, not the vaccine, but things like PrEP, one of the conversations that's been going on a lot lately in the HIV community is that people are concerned that if they give people this pill to take before they have sex, that they're just going to go out and have risky sex. And unfortunately, in the adolescent and young adult population, that's probably more likely to happen than in an older population. What I would strongly suggest is that even if an HIV vaccine does come to fruition, which at this point in time I'm highly doubtful it's going to be anytime soon if it happens at all, the virus simply mutates too quickly. And there are too many strains of it, and with each strain you would need to have a different anti-vaccination protocol. That at this point in time, I don't see the vaccination being as much of an issue with people's behavior, but I do see something like PrEP becoming more of an issue with people's potential risky behavior. People did ask a couple of questions specifically about dentistry and about sterilization. So this is one thing I'd like to reassure all of you as somebody who lectures on this from New York State. There are very specific protocols in what we as dental providers or medical providers have to do to maintain the sterilization of our offices. And specifically, somebody was asking about, what about if you're drilling on somebody or using a water hose, and is there any backdraft with that? And yes, there is. So the protocols include flushing out of all the water lines for 2 to 4 minutes every single day before you're seeing any patients, making sure that the water is tested. So we do water testing here at the facility this is a mandatory thing. So we do water testing, checking lots of different chairs all the time, but we do it every 6 weeks. We have an autoclave which sterilizes all of our instruments, and we have to monitor the autoclave, so we have to do spore testing for the autoclave. So we have to make sure that nothing is able to grow. And so that gets sent out every single week, and we have all the data in the world if you ever want to see any of this. In terms of my being concerned with my own self being exposed, I've had exposures. I don't know anybody who's a healthcare provider who hasn't had exposures, but you deal with it on an individual basis, and you try and make sure that you talk to the patient, you find out if they've ever had an HIV test, whether or not they know what their HIV status is, you talk about what kind of medications they're on, if they know what's going on. You offer to have them have an HIV test, which is mandatory by New York State and actually must be paid for by the dental facility or the medical facility. And then you can start figuring out what you want to do. Most people who've had an exposure with a patient who potentially is HIV positive, or they know what their HIV status, will automatically go on post-exposure prophylaxis for at least 28 days. And there's good and bad in that. It doesn't feel so good, but on the other hand, it's life-saving. And the other question I have, which is a brief question, which is why did I become an HIV/AIDS advocate? Basically, I became a doctor in Manhattan in the mid-'80s and did all of my training at all the hospitals that I did for pathology at AIDS-designated centers, and walked into the AIDS Institute one day when I was 26 and said, you don't have anybody lecture on oral manifestations of AIDS? And they said, you're right, we don't. Would you like to do it? Come back next week and give infectious disease grand rounds for New York Hospital. I said, okay. So that is kind of how I wound up in this business. And also because I had friends who were sick and I had friends who died, and I want them to be remembered forever. So this is for Stephen.